Alrighty. Happy Friday, everyone. Thank you for joining us for the September Crucial Conversation. We do this series as a way to bring up topics related to maternal and child health. This is really open for anyone to learn, anyone who has interests in the topics that we're talking about. We do hope to see you all coming back for more learning with us as we go. We typically host one of these a month. And so we have a great lineup this year I think we're through March right now with our lineup. If you would like to be included as one of our speakers, if you have a topic related to maternal and child health that you would like to share, please reach out to me and I'll give some contact info at the end here. We are going to get started and kick things off today. So I'm very excited to welcome one of our doctoral students in the epidemiology program. Tanveer is a public health researcher with a demonstrated history of working in research institutions. He is skilled in clinical research, medical education, epidemiology, interpreting and analyzing data and medicine, really looking at the intersections. He has strong healthcare service experience, so he has a Master of Public Health degree focused on epidemiology, and his research interests focus on improving childhood pneumonia, maternal and child health nutrition, vaccine trials, and other infectious diseases. So we're really excited to bring his perspective to the conversation today. What you're going to hear about today is some of his work related to international clinical trials. So I won't give too much away with the introduction here, and I will leave some space for Tanveer to tell you a little bit more about himself. But we are really excited to present today's topic, which is Tiny Bubbles, Big Impact, Fighting Childhood Pneumonia with Bubble CPAP in Africa. I'm ready to turn things over to you. You ready? Okay.
Thank you. Thank you, Dr. Alicia, and good morning, all. Dr. Alicia already gave a very nice introduction about myself, but if I like briefly introduce me, I am Tanveer Faruk. You can call me Tanveer, a PhD student in epidemiology here at UNC Charlotte, and also continuing my research activity as an assistant scientist with ICDDRB Bangladesh. And today I will sharing a story, like a complete story of our full journey with Bubble CPAP, which is an ultra low cost innovative device that can save the children with the severe pneumonia, the leading infectious killer of children under 5 worldwide. Our works started at ICDDRB in Bangladesh and expanded into large multi-hospital trial in Ethiopia, where we tested feasibility and effectiveness of the device under real world and resource limited settings.
Tanveer, can I just interrupt quickly?
Yeah.
If you have slides, can you share your screen?
Yeah.
Okay,
Sure.
lovely. Thank you. Just want to make sure we have that functioning right.
Okay. So can you see my slides?
Looks perfect. Thank you.
Okay. We actually from started our journey from busy wards, pediatric wards in Dhaka Hospital of ICDDRB to district hospitals in Ethiopia. Our journey has about overcoming challenges and building collaborations and seeing how innovation can reach the children who need it most. Today, I would love to take you on that journey with me. So I think you will get a complete idea behind a successful clinical trial in low resource settings. So basically, our Ethiopia trial stands on this published article that has published in the Lancet back in 2015. And our study was a randomized control trial. We assigned the 3 groups to our study. One group that will take oxygen treatment with the standard low flow, which is the standard treatment for the under 5 children with severe pneumonia. And another group will receive oxygen with high flow oxygen. and another group received oxygen with our innovative bubble CPAP device. So in the result section, you can see the red mark section. We actually found that children who received oxygen by bubble CPAP had significantly lower the rates of death than the children who received other oxygen therapy. If we can like very simply elaborate this line for you, that actually the children who was getting bubble CPAP actually reduced 75% of the death if you compare to low flow oxygen and the high flow oxygen. That is actually a huge number, 75% death reduction. So we had some immediate after effect of our publication. Immediately after the publication in our hospital, the routine use of the bubble CPAP has introduced to the management of the children who admitted to our hospital with severe pneumonia. And the years following the trial, the death rate also significantly reduced. In the next slide, I will discuss very simply how the death and the other things looks like after the trial period. And it not only reduced the death, as a non-profit organization, we always try to save money from different resources. So overall cost of the oxygen consumption in any hospital, it's a great source where you can cut the price and save the money for you. And you can see reduction of the use of oxygen consumption from 30,000 US dollar. Now it become, after the trial period, we are having less than 10,000 per year. This is another uh, immediate effect after our publication. And it also receives People's Choice Award for Most Promising Childhood Pneumonia Innovation in World Pneumonia Day in New York City back in 2015. And you can see, okay, are you watching my slides perfectly?
There's a small black box on my screen above the at the top. So if you could just tell me what's at the top, the title of that, that would be great. But otherwise, we could see the numbers and the bars fine.
Okay, let me. Okay, can you see?
Yes, thank you.
Okay. So this is the graph I'm talking about. In your left-hand side, you can see the graph showing the rate of mechanical ventilation use, and with the purple color, it is the pre-trial period, like before using of bubble CPAP in our hospital. So you can see the lots of patients went under mechanical ventilation. It is due to the current treatment for the managing severe pneumonia was not working, and patients, after the treatment failure, patients easily went under the mechanical ventilation. So lots of mechanical ventilation. Now after the trial period, you see how drastically it reduced to 7% after the post trial period. So that is how we can save like lots of oxygen consumption use. So that's why we save lots of money on the oxygen supporting our hospital. So in the your right hand side, there is also, you can see the pre-trial period, the mortality rate bar was really high, and after the post-trial period, it is now it's very low. It's currently it's even the 3 years, 3 or 4 years back data. Now currently it is less than 3%. So this is actually tremendously saving the lives of under 5 children in a very low resource setting, where we have like less support for children in the ICU settings, and also we have very low resource for the mechanical ventilation. Actually, those kind of condition, it is very suitable for our device to use and save lives. And if we can also see the global challenges currently with the children under 5, we can see the major killer of the children are the disease are like malaria, pneumonia, diarrhea, HIV, and tuberculosis. Very interestingly, these diseases all are preventable and treatable. But still, lots of children are killing worldwide every year. You can see on your right hand side here, pneumonia is the leading infectious cause of death among children under 5, killing approximately 700,000 children per year. That is a huge number. And although this is the entirely preventable this disease, and still physicians and scientists cannot uh, align in a same position to fix one thing to save those children uh, due to some linkage. So pneumonia actually strongly linked with undernutrition and lack of safe water and indoor air pollution, inadequate access to healthcare. It's all happening in the like low and middle income countries like Bangladesh, Nepal, and African countries like Somalia, Tanzania, Ethiopia. So that is what happening with the children under 5. And if we can also see the WHO bulletin, and you can see the sub-Saharan Africa still continue to have the highest rates of mortality in the world at 74 deaths per 1,000 live birth. It is actually, if you compare to this with children of Europe and North America, it is actually 14 times higher than the risk for children in Europe and North America if you compare to sub-Saharan African countries. So children under 5 are already having those challenges in those countries, and that is why actually we decided to study our design in Ethiopia. And behind that, why main reason, the World Health Organization already identified 6 different countries where pneumonia-related deaths are still very high, and Ethiopia is one of them, and that is one of the main reasons why we like design our study in Ethiopia. And if we can briefly discuss how we design our study in Ethiopia. So this was an open cluster randomized trial in 12 general hospital, and we also call it as the 12 district hospital. In my different slides, you see district hospitals and the general hospital. I mean, as the same, and we actually randomly assigned 6 hospitals to bubble CPAP for the respiratory support for children with severe pneumonia, and another 6 hospitals with the standard low flow oxygen therapy, which is the current treatment plan for treating severe pneumonia of under 5 children in the current guideline of WHO. We actually calculated effectiveness as the relative risk of the outcome in the bubble CPAP group versus the low flow oxygen group. And all the sites included in our study located at an altitude less than 2,500. This is very interesting, like different heights also related how much oxygen your body needs. So that's why we justify all the study sites. No study sites were above 2,500-meter height. And if you can see the whole journey map from starting back in 2017, and we finally recruited our final patients from stage 3 in July 2022. You can see we had to collect like lots of approval for this trial. First, after developing our protocol, we have to get the IRB approval from our collaborative institution, which is AHRI, Ethiopia. And after that, we need to collect approval from the National IRB of Ethiopia. And one of the most challenging for us to collect the approval from the FMHCA, which is now called as Ethiopian Food and Drug Authority. It took almost like 11 months to get the approval. Like after all the approval, we finally start our stage 1 trial in 2019 September, and it's stage 2 trial in another district hospital in 2020, and finally we recruited our final patients back in 27th of July 2022. And if we can see the whole journey with the pictures. I would like to talk this today's talk without any complex statistical table, but I want to give you a complete sense behind a successful clinical trial. What are the challenges you might face if you plan to study in Africa or South Asian region, and what are the needs you should keep in your mind. That will actually give you a complete sense. So I would like to do that in my talks. So if we can see the this whole things through the pictures, it will look like this. Basically, back in 20 last phase of 2017 and 2018, I was completely busy with writing protocols. My job was for in this 6 month period to write the protocols, update the protocols, and replicating the same protocols for the African country. Like we try to replicate our Dhaka protocol and try to replicate our results in a different country. So we need to take lots of things from our original protocol, and but as the for the cultural and also some other factors work in the Ethiopia, so we need to change a lot. And in the meantime, we also need to communicate with our donors, for because that time we are not sure about who will going to support our study. So we are also exploring different donors for our clinical trial. So finally, we got the green signal from Swedish SIDA. They were agree to support us for the whole time. This from originally we designed our study for 2 years of time, but due to the COVID and other political chaos and different obstacles, our study actually need like 4.5 years. And immediately after the acceptance of the protocol, and we got all the IRB approval from different institutions, Ethiopian investigators actually they were invited to Dhaka Hospital of ICDDRB in the pediatric ward to have a actually hands-on training with the device, how the device actually work with the children, and what are the technical difficulties before starting the device. It is actually very simple, and for that session actually help them to understand the simple procedure by hands-on training. They had a great time during our hands-on training, and they also enjoyed sightseeing of a different location of capital city of Bangladesh. And immediate after their visit, our investigators team actually visited Ethiopia. Initially, we planned to study in 20 different hospitals of Ethiopia. So before choosing your study sites, you need to check the feasibility of those sites. As I mentioned, in a clinical trial phase, it is actually there are 3 to 4 stages needed for a complete clinical trial. And during the stage 1, you have to see the feasibility of your study, whether it is feasible in that study or not, and how the physicians and the other study staff accepting your new treatment method, because they are already used to with method for treating children with severe pneumonia, and how they will accept the new method. This is very important to see the feasibility in stage 1. So that's why our investigators visit all the sites and to see the feasibility of the trial. In the meantime, our study already made the headlines in different national and international newspaper and news media, including BBC and CNN. So all those headlines give act as a great motivation for our team, because our team this was the first time our team from ICDDRB work in another country and stay there for a long time and monitor everything there. And we understand that we need some support and motivation, and those headlines and interviews really help us to motivate and proceed forward with the study. So I would like to share a like great motivational interview with CNN with our principal investigators of this trial, Dr. Jubair Chisti. So this interview actually greatly motivate our whole team. So that's why I need to share with this interview with you. This is just 3-minute video. I hope you all will enjoy this interview. Okay, let me go to the interview. Hopefully you can see the video without any interruption.
And healing takes many, many forms. One doctor in Bangladesh created miracles when he repurposed a simple plastic shampoo bottle and used it to save infants suffering from pneumonia. In many other developed countries, hospitals use low-flow oxygen, a low-cost alternative to ventilators, to help patients breathe. It is a recommendation by the World Health Organization. But as Dr. Mohammed Chisti saw in his first night as an intern, the success rate of these methods is very low. Let's bring in Dr. Mohammed Chisti of the International Center for Diarrheal Disease Research in Bangladesh. He joins us from Dhaka via Skype. And Dr. Chisti, thank you so much for joining us. The WHO says that pneumonia is the leading cause of death in children around the world. You know, we know that first world hospitals, they can afford expensive treatment and ventilators. But how much does that type of treatment, how much does a ventilator cost, and how much does your device, using a simple plastic bottle, cost to make?
Actually, mechanical ventilator is highly expensive. It is cost at as high as $15,000. But our device only costs less than $2.
Incredible. It costs just $2 US. You're just using a shampoo bottle. And I know that you've introduced this plastic bottle designed to hospitals there in Bangladesh. Has it worked? Have you been able to save lives?
We had a trial for 2 years, which has been shown that it was associated with 75% reduction of mortality in childhood severe pneumonia and hypoxemia in under 5 children compared to WHO standard oxygen.
This is incredible. It's a remarkable innovation. It appears to be working. You've discovered this simple but very inexpensive and effective way to treat pneumonia in children by using, again, a plastic shampoo bottle. How does it work?
Mainly works that you know that when a patient takes oxygen through nasal prong, then he or she exhales air. That air usually passes through that water-filled shampoo bottle, and it produces bubble. That bubble gives the back pressure, and by this back pressure, lung remains open. And you know that in case of pneumonia, there is loss of lung volume, and that back pressure recruits that lost volume that has already been lost during pneumonia. As a result, oxygen can easily diffuse into the blood. This is why it usually works. Then respiratory distress become ease by the fact that it actually reserves the functional residual capacity which actually needs to breathe easily for a kid.
And understand, you've been sharing your innovation to the world. Do other hospitals in developing countries have plans to use your design?
Yeah, already government of Ethiopia and Nepal expressed their interest, and we have already started work in Ethiopia in 20 hospitals. Hopefully, by the next 2 months, we are going to start implement there, and it might take 2 years. We have already visited those 20 hospitals, and they are perfect for the implementation there, because the pneumonia-related death in Ethiopia is also enormous.
The idea is spreading, and that is very good news. Dr. Chisti, thank you for joining me.
Thank you.
And healing takes many, many
So yeah, okay. I hope you enjoyed the interview. So this actually worked as a great motivation for me, as I worked there for like long 6 years, and this kind of motivation need us to go forward. And okay. And actually, after the initial visit of our during the study site visit, we understand the what are the challenges in the different area. And I think there is another black line in the. Can you see my full slide? Yeah.
Yes, it looks good.
Okay. So this is after the visit of our 20 hospital. Initially, our plan was to study in 20 different hospital. Then we reduced our hospital sites to 12. And I will come why we reduce our hospital. In stage one, we see the feasibility of this device with two district hospital and two tertiary hospitals in stage one and two. And after the feasibility, we also started our stage 3 trial, which was the effectiveness trial in 12 district hospital of Ethiopia. And our team needs to like moving all the time, all the 12 hospital within 1 month of time. We had a monitoring plan, like every 1 month we need to visit 12 hospital to see the any difficulties with the or the challenges the hospital staff are facing. And we also have the every 3 months we need to train all the study staff, because in those hospitals turning over of the staff was like very frequently, like within like 3 months the staff are transferred from one hospital to another, so we need to give the training to the new staff. So that is why every month we need to visit all the 12 sites regular interval. And if we summarized our findings from findings from the trial, like it actually replicate our trial from Bangladesh. So what does that mean? Actually, bubble C PEP oxygen therapy, and now we can say it is feasible to implement in district hospital of Ethiopia. And this therapy was found to be also beneficial for treating childhood severe pneumonia and hypoxemia in district hospital of Ethiopia if we compare to current treatment plan of WHO to treat patients with pneumonia. And thus, this treatment can be implemented as the part of the standard of care treating childhood severe pneumonia and hypoxemia in low and middle income countries, where still low flow oxygen therapy is the standard of care. So that means we almost replicate the same result from our Dhaka to a different country. That is a huge success for our team, and we finally disseminate our result with the Ethiopian Health Ministry. And the Ethiopian Health Ministry was very happy, and on the same dissemination program, the Ministry of Health actually announced that they will take this treatment for the scale-up trial. They want to take this method to other district hospital of Ethiopia. So that is very good news on the dissemination. And finally, all of our hard work actually recognized by the prestigious Lancet Global Health Journal. So now our both study, like a study from Bangladesh and study result from Ethiopia, now published in the Lancet. That is another success of our trial. But I mentioned earlier, like if you go and study there, and you need to find success, and you have to always keep in your mind, you might face like lots of challenges, like working there. It might be like language barrier, some cultural barrier. So you need to keep all the things in your mind before go there and study there for a long time. So our study also nothing new. We face the same thing that challenges in a different district hospital. So the first major challenges I mentioned it earlier, like as we need to take like lots of IRB approval from different organization and institutions. So long waiting time before getting the approval from Ethiopian Food and Drug Authority. Actually, it took 11 months. And if your study is funded by donor, it is very difficult for us and also difficult for the donor to like sit idly and want to hear the approval result for very long time. It is very difficult also for us to do like write proper justification, like why is the delay actually occur at that time. So we didn't have like proper justification of that delay. So and also that was the peak COVID period at that time. Some of our travel was were restricted at that time, but finally, we decided to fly to Ethiopia, and several face-to-face meeting actually solved the issues. There were some like political and the language barrier and cultural barrier there. So finally, uh, like we did like 5 to 6 face-to-face meetings with the reviewers, and finally we got the approval from the Ethiopian Food and Drug Authority. And another challenge, we need to change our study protocol. I mentioned it like several times, like from 20 study site to 12, that due to the time was killing during the getting the approval, 11 month, almost 1 year has been lost from our study. So due to for constraint of budget, we need to cut down our hospital from 20 to 12, and also some political chaos at that time because Ethiopia was there was some internal war going on at that time. So from the local government, we got the suggestion that for our staff, it is not safe to go some of the study sites. So we decided to like agree with the local government, and we decided to study in 12 hospitals. And another interesting thing we found that before commencement of the going to the actual stage 3 trial, we actually collected the all the data from the those 12 sites, like, and then we found like 12 months period the fatality rate was very low. So we cannot have our primary outcome as a death. So we change our primary outcome from death to treatment failure to attain the adequate power for the study. This is another good experience for us in low resource settings, and also in countries where like some there are some beliefs like actually the fatality rate you can see it's very low, but on the paper it is very low. But if you can know the actual history from our qualitative study, we understand that there were some local belief or some cultural belief that when a physician like discuss the actual condition of your children with the caregivers, father and mother of children, and that time they actually decided to take their children home. So lots of the death occur uh, inside of their home instead of hospital. That is why actually on the paper they have very low death rate. So this is also an important thing we need to keep in our mind, that on the paper the death rate and the actual scenario behind it actually will not match with the paper. So you need to do a qualitative study also for this kind of trial if you need to understand the actual scenario behind this. So this is another great experience for us. We also need to expand our study to different low resource settings country. So we will keep this thing in our head. And this is another challenge for us, like during the time of severe scarcity of water, especially the time of May to August. Those 4 months was severe scarcity of water in every corner of Ethiopia, and importantly in the district area of the Ethiopia. And we like in the picture you can see in the morning I have to like work as a trainer in different hospitals, but in the evening I must act as a water collector because we had only like 30 minutes time where the like water supplied to our dorm. So we need to collect as much water as we can during those 30 minutes time. So this is one kind of challenge we face during those 4 months of time. And this is the local food of Ethiopia. We call it injera. And in every district area, it is easily found. But for the initial like 2 to 3 months, it was very difficult for me to digest this food every single morning. But after I'm seeing my lots of Ethiopian friends and lots of my colleagues in Ethiopia, I found they are very healthy and they motivated me to like take this food because you can see their bread and roll, these are like very healthy like homemade things, and it is full of starch, full of starch and fiber, and they are very good for your digestion. And finally, I am enjoying injera every morning. So for my last 6 years of time in Ethiopia, I enjoyed Ethiopia every morning. Okay, and this is another challenge for me. When I was posted in Ethiopia, my elder son was only 2 months of age, and due to the like very bad internet like service in district hospitals, I was not able to see the development of my kid that time. So most of the time, I hear from my wife that how my son is doing, what are the new words he can tell. So this is kind of a challenge for me, but of course, other thing work motivate me to like save those children where like resources are very limited, and I'm working for them. That actually also motivate me to go forward. Whenever I feel for my son, it also give me some motivation that okay, so same children are coming with severe pneumonia and hypoxemia and they are dying, so I'm working for them. So this actually helped me to get going. And I told you before that during the peak COVID time, we cannot just sit in our dorm or sit in the capital of Ethiopia and we can monitor, but we need to go every sites within 1 month of time. We need to complete 12 study sites. So for where we suppose if three hospitals in a distance of like 5 hours of drive within those hospitals. So we took the cars to go there. Effectively, we cover three hospitals in a single day and monitored those area. And where we think that like two sites are very like away from like two sites are in a two corner of Ethiopia, we took the plane journey to go reach there. And we also need to think about our budget, like what are the budget actually we have for those travel. So we plan our trip accordingly to the budget. And sometimes we took the three-wheeler to reach the hospitals within like 1 hour or 2 hour distance. So that is how we complete all the 12 sites during the peak COVID period. And This is another challenge we faced in during the training phase in the different hospitals. So in the different district hospital of Ethiopia, they have a trend to rotatory duty. Some European doctors, pediatrician always come in 2 years of contract. So if you can see the physician in your left hand side, that doctor came from France, and she knows only French language. And the physician in your right hand side, the lady from Italy, and she knows only Spanish. And for me, it is very difficult to communicate with them. So there was a senior staff nurse who actually knows both French and Spanish language. So she actually translate my all the things to them. And also after that, we decided not having the training in the classroom settings. We decided to go to the in a pediatric ward or clinical ward settings where I can show them the whole things practically. So it is actually like reduce our barriers, language barriers. This is another kind of challenge we face. And if you plan to study in African region, you have to have a very good relationship with these friends, because I faced almost every day like one of them sitting in front of my dorm door, like when I came from a hospital visit every night. But initially, my local drivers and my local friends helped me to get enter to my room. But after like 2 or 3 months, they actually understand I'm not their enemy, and then they automatically give room to me to enter my room. So this is another thing you need to keep it in your mind. These friends will ultimately come to your way during your stay in African region. And actually, I gave like lots of prompt to Google Gemini to like give me one picture of our challenging moments in Ethiopia when actually government of Ethiopia announced that every Ethiopian citizen should register a gun from tomorrow morning. And that announcement actually gave our team a horrific time. And after that news, like me along with my female colleague, we were two at that time in the different district hospital. So we needed to do a COVID test before fly with a plane. So we don't know where to go during the midnight for a COVID test. And the district hospital, it is very rare that after 12, a center was open that time for the COVID test. So we were like past a very horrific time. And finally, with lots of obstacles in on the road, we reached the airport. And every checkpoint we had to like show our papers that we are not from Ethiopia, we are international citizen, as the government announced that all the international citizen must evacuate the country within next 12 hours of time, and all the citizen of Ethiopia should register gun for take part in the internal work. So it is very like chaotic time for us. And finally, we reached the airport and went back to home. But some of our friends and colleagues are very discouraging us that after that incident, like don't go back there if the political situation is not stable. But actually, after that incident, we visited Ethiopia like 6 or 7 times more, because our only sole goal was to like successfully finish the study and safely by effective planning, and no matter what the obstacles. And we got like lots of local support from our colleagues from Ethiopia that time, like how we need to move, like what day we need to move to monitor different hospitals. So what are the places are not safe. So we actually took all the suggestion and advice from local government and my Ethiopian colleagues that actually help us to complete our study safely in 12 hospitals. And I am just talking about all the challenges, but after like all the challenges, we found like lots of opportunities through this whole journey, like lots of future collaboration. We had like lots of good collaboration with like University of Washington at that time, like during our work, like some other clinical trial ongoing on those hospitals. So we had lots of collaboration with different universities of different countries, lots of international stakeholders, and actually we found a multidisciplinary team members for unique collaboration. Picture above, you can see the Professor John David Clements. We found a great epidemiologist for any kind of study, and he is also a great mentor for all of us. And we found lots of junior young researcher who was very brave and ready to move to any corner for any kind of study. And we found brilliant pediatricians, statisticians in that study and during the whole period. So this is very positive thing through the successful trial. And another thing, we generalize some complex procurement process for any kind of trial that held in outside of your country. So it is obviously, if you start your journey alone, this kind of challenge you face, but after that you can generalize those for others to take help. And now any institution or any team from our research institution, they can seek help, like how they can procure or purchase any study equipment and transfer them to other country. So due to different economical and financial barrier, we need to order all the top quality oxygen concentrator for our study sites from Netherlands, and we completed the payment from the banks of United Kingdom. So why? Because if we take the permission from our government, it will take more time, and we don't want to go with that plan. So that is why, as a non-profit organization, we took help from the banks from United Kingdom, and we finally transferred all the equipment to our study sites in different corner of Ethiopia. So these are the things we understand from our journey. And ICTDRB's footprint to the global south, it is another remarkable thing we got from the successful journey of this trial. Now ICDDRB can lead or co-lead different clinical trial, and successful completion of this project actually enhanced the ongoing construction of South-South collaboration. It is very positive things for us nowadays. We don't need to wait for some Western country or some other donor to help us, but now we can go and design and lead with other countries need help from us, and we can make the South-South collaboration in a successful journey. And it really enhanced by this trial. And if we can also discuss how our trial, this innovation can be sustained in the future. So it is very important to note that locally made bubble CPAP is ultra low cost. It requires exactly $1.25 US to make one device for one patient, and it can be used multiple use can be done in the pediatric ward with single device. And we are also trying to scale up bubble CPAP widely in Ethiopia. Currently, already scale up study is ongoing in Ethiopia in more larger scale, with including 50 hospitals, and then also in scale up study are ongoing in Nigeria and Malawi. And we have a very advanced talk with Pakistan and Nepal to see the opportunity there. And very recently, I had a discussion with a couple of senior members from Duke University. They are working in the Duke Clinical Trial Institution. So we are discussing about some opportunity in Sri Lanka, how we can work and implement this in Sri Lanka. And simultaneously, the WHO may change their policy and adopt bubble CPAP as the part of the standard care for the treatment for severe childhood pneumonia and hypoxemia in their guideline. And we are actually like planning to discuss with WHO next year after the trial from either from Pakistan and Nepal, and during the time we will get the result from current scale up study which is ongoing in Ethiopia, Nigeria, and Malawi. So these are the great opportunity. We can also change the policy for the treatment of under 5 children with severe pneumonia. And if we can see the like actual scenario of our innovative method with the bubble CPAP, and you can see in this picture the plastic bottle. It is like transparent plastic bottle. For the study, we actually order it from a vendor, but it is very cheap. And with the 10 centimeter of water, distilled water, you can put on it. And the regular use of oxygen prong and oxygen concentrator, either way we can use. Any hospital, if the hospital ward having only oxygen cylinder, we can use the oxygen cylinder. And actually, it is better to use the oxygen from the oxygen concentrator. So we just make the oxygen prong and connect with the infusion tube for the convenience of the patients, because in when the patients or children getting the oxygen support, the patients also need the nutrition from the mother. So that is why, for the convenience, we make the oxygen prong, that tube, a little bit longer with connection with the infusion tube. And the one part of the infusion tube goes under the bottle and it produces bubble, and another portion getting oxygen from the concentrator. The one of the important thing from how it differs from regular oxygen support. In the regular oxygen support, your child can only take the oxygen from the concentrator or the cylinder. But from our device, the special mechanism, the produced bubble in the bottle, that actually give the back pressure, and that back pressure actually helps all those collapsed alveoli to become in a normal shape and make the lungs normal functioning, so that the oxygen you are giving, that will actually help improve the breathing of the children. That is the main difference from conventional oxygen support to bubble CPAP. That is why we name it as a bubble CPAP. And you can see currently Bangladesh government also see the take initiative of to take it as a integrated IMCI guideline to their local guideline to treat patients with severe pneumonia. And we are now in a phase to develop our protocol for implementation research. And still we need some support from the donors, and we need to attract them by dissemination, training, workshop, and different national and international stakeholders. Meeting can be a successful way to attract the potential donors. And another thing I must need to say, like if anyone from our UNC Charlotte MCH group want to study want to plan for a clinical trial, not only with children with severe pneumonia, you can come up with any idea. You can use me as a great resource, as a great media, because I had like a good collaboration with different low resource settings, and how to get those IRB approvals, and how to get going, so how to take the initial step. I can help any one of you. So you are very welcome to you can use me as a media for any kind of clinical trial. If you want to plan in different African region or in Southeast Asia, just contact with me. I'll be there for helping you. And it actually gives you a like great feelings, like if you really plan your study in a very low resource setting where actually people need your study there. They need this kind of research where actually they have like plenty of challenges they are facing nowadays. It will give you a like great feelings after the successful completion of your study. Like I know we are busy with the different kind of research and activities, but this kind of study can really give you like a inner peace, and you will really enjoy working with the different diverse team and diverse culture. So I hope yeah, you can plan and contact me if you plan to go with a clinical trial in the future with any kind of topics not related with only with severe pneumonia for the children. And I need to give my special thanks to Bubble CPAP study team of Ethiopia, also the local PIs from both the countries, from Ethiopia and Bangladesh, and all my co-investigators. And I'm also very grateful to UNC Charlotte Maternal and Child Health Work Group for giving me the opportunity to share my experience with all of you. I hope you enjoy my journey. And if you have any questions, I'm taking all of your questions.
Thank you, Tanveer. We really appreciate you talking to us about this incredible work. It is clearly so impactful. And so just for the folks that are hanging on here, I know we're at 12 o'clock. Thank you for sticking with us. If you would like to connect with Tanveer, if you have questions, his contact information is on the screen now. You can also connect via LinkedIn. That would be great. And then we do have some references that I'll drop in the chat for you if you would like to check out the 2 articles that are in the Lancet related to this work. Please do check them out. They're really impressive. And then I just wanted to plug, we recently released our September newsletter. If you didn't get a chance to see that in your email, please go ahead and I'm sorry. That's the word that I'm looking for. Scan is the word that I'm looking for. Scan that QR code there so that you can get access to different opportunities that are happening. We would love to see you all throughout the next month. And then remember that this will be posted on our YouTube channel. So hope that you'll be able to share it with others if you think that this talk would be interesting to other folks. Thank you, Tanveer, so much for being a part of our conversation today and for bringing this issue to light.
Thank you.